Hi, I am Dr. Janice Williams. This lecture will introduce you to neurological disorders for the advanced practice clinician. During this lecture, we will focus on differentiating between the different neurological complaints that a patient may present with. We will look at some of the different neurological disorders such as seizures, Alzheimer's, dementia, Parkinson's, and even some that will be classified as infectious or inflammatory, such as meningitis, bacterial, and viral. Throughout this lecture, I want you to kind of chart for yourself what is the neurological disorder or complaint? How do you assess that patient? What are some of the clinical manifestations that your patient may present with? How do you examine a patient who presents with neurological disorders? What review of systems? What physical exam? And then I want you to also think about what would be your differential diagnoses? How would you rule those diagnoses in? How would you rule them out? And then what treatment plan, both pharmacological, educational, diagnostic-wise, what is that treatment plan that you will have for your patient and their family? Let's start by just talking about some current common neurological complaints that a patient may come in with. When you think about a patient who may be experiencing some confusion, or what we would also like to define as the inability to think quickly or coherently, there can be other diagnoses or conditions you need to be thinking about related to those patients. An example of that would be patients who may present with either dementia or delirium. Both can come in a confused state. However, the difference would be that a patient with dementia has a decline in their neurological status over time, whereas a patient who has delirium, it's usually an acute confusional state. It happened recently. There can be multiple or diverse causes for both dementia or delirium. Some of the causes you may want to think about is things such as infections, hypoxia, or even neoplasms or cancer. Let's now talk about dementia. Okay, when we look at dementia, which is a degenerative disorder that impacts the neurological system, we're going to look at it first by defining what is dementia. What are some of the clinical manifestations? How would you treat this patient, both pharmacologically and educationally? And then what would be some of those differentials that you need to consider? Dementia is considered a neurocognitive disorder that is characterized by deficits in cognitive function, with a significant decline from a previous level of functioning. This decline may be evident in one or more areas of the patient's functioning, which can include their attention, their language, memory, their visual spatial skills, or even their executive functioning. When you think about a patient who may present in your office who has dementia, some of the things that they may present with is this gradual onset. They may have some memory and language issues. They may even present with some depressive symptoms, delusions, hallucinations, and agitation. There are diverse types of dementia that patients may present with. So we have the vascular dementia, the Lewy body dementia, the frontal temporal dementia, and each one of those may present a little differently. So when your patient has dementia, you want to first just collect the information, do a good physical exam on this patient. These are patients too that you will definitely want to refer for further evaluations to a neurologist. But when you're doing that physical exam, you want to include not only what does the patient look like, but you want to listen to their heart, lungs, and their abdomen. You want to feel their thyroid, and then do a comprehensive neurological exam. And you want to do screenings on your patient that can include things like a geriatric depression screening scale, your PHQ-2 or 9, and then your Beck depression inventory scale. You also want to evaluate what is their functional level status, okay? There is a scale referred to as the Rexburg Functional Assessment Staging Scale. I have included the links to these different tools that you can utilize to screen your patients if you believe that your patient is experiencing dementia. Remember, these are screening tools. These are not diagnostic tools, but they will help you in evaluating your patient. Some of the other tools that you can utilize on your patients is using a mini mental state examination, and they also have that clock drawing test that you can utilize on your patients. These will help you to be able to stage your patient. But once you believe that your patient is experiencing dementia, you also would want to do some evaluation via lab work. This will help you to rule out other possible causes that may be a contributing factor, help you with your differential diagnosis for these patients. There is an acronym that you can utilize when thinking about the differentials with a patient who may present with dementia. And the acronym comes from the word dementia. The D stands for drugs or depression. The E, is it an emotional upset? The M is metabolic. Is there a thyroid disorder? Is there a vitamin B12 disorder? The E stands for the ear or eye impairment that is preventing them or reducing their ability to utilize their senses. The N stands for things like normal pressure hydrocephalus. The T is for tumors or masses. The I is for infection and sepsis. And the A is for anemia. So again, the acronyms for differentials that you want to think about the word dementia, and each letter reflects something. As you are learning in your pharmacology class, there are medications that will help to decrease the rate of decline in patients who may have a cognitive impairment related to their dementia. We have medications like diazopril, rivastatin, galactamin. These are all medications that can be utilized to reduce the decline. It does not cure a patient, but it can reduce their decline. There are also medications that can be used for moderate to severe dementia. These are like Namenda that your patients may utilize. So what are some of the other common complaints that a patient may present with related to the neurological system? They may talk about dizziness or vertigo and even headaches. When we think about dizziness and vertigo, the episodes of dizziness are usually brief and mild, and they can also progress to a prolonged or severe state. Patients may present talking about having unsteady gait and even some vertigo, which occurs with nausea and vomiting. When you do your eye exam, you may see some nystagmus, but you need to make sure that you consider what differential diagnosis that you may need to be thinking about with these patients who present with dizziness and vertigo. Your assessment of these patients would include doing a comprehensive neurological exam, and there are some specialty tests that you learned about in your advanced health assessment course that I would definitely recommend that you review in order to understand how do you do a thorough evaluation of your patients who may present with dizziness and vertigo. There is medications that can be utilized, such as meclizine, that can help hopefully reduce the symptoms that your patient may be experiencing. When examining these patients, you can do the Hill-Pax maneuver to evaluate if you think that there is an imbalance within the conductive stones or crystals in the ear. And you learned about that examination in advanced health assessment as well. Another neurological complaint that patients can present with is headache. There are two categories in which we categorize headaches, primary and secondary, and their causes can vary. When patients present with a headache, you want to make sure you do a thorough review of systems and also ask pertinent questions within all that you learned about in your advanced health assessment class. Treating patients with headaches can vary. It can range from treating them with an NSAID to migraine medicines, but it's important to be able to categorize what that headache is. They could have a tension headache, a migraine headache, a stress headache, and each would be treated differently. And the frequency of those headaches would also warrant the type of treatment in which you would do for these patients. If a patient presents with the worst headache of their life, that would usually be considered a emergency, and they should be evaluated. CT scan should be performed to rule out more severe complications that can be life-threatening. Another neurological complaint that patients may present with is talking about paresthesias or paresis. That is a numbness or tingling, which is along the peripheral nerve pathways. And then you want to make sure that you think about what are the differentials that may be applicable to that. Patients can also present with tremors. That's that rhythmic, involuntary, oscillating muscle movements across the joints. When and if somebody presents with tremors, you want to be thinking, is it Parkinson's? Is it medication induced? Is it alcohol induced? So asking the appropriate questions and examinations being performed that is comprehensive to rule out or rule in those. Now what I'd like to do is talk a little bit about a degenerative joint disorder, neurological disorder, referred to as Alzheimer's disease. Alzheimer's disease is a progressive neurodegenerative condition, and it's a form, or the most common form, of dementia. There are some things to do that you as a clinician would attempt to evaluate this patient in a manner which would allow you to think about them holistically. So what I mean by that is patients who have Alzheimer's disease, it's not just about providing a medication, but it is helping that patient to have connections with services that will give them the best quality of life, depending on the stage and the state in which they present to you with. These things would include things like their nutrition, their exercise, preventative care, social services, resources, and maybe sometimes even giving them strategies and tools that would help them with being able to remain as independent as possible, but yet still remain safe. Alzheimer's disease is defined as a disease that is related to the dementia, which involves memory loss that eventually affects an individual's level of independence. Alzheimer's disease is a brain disorder that is irreversible and it's progressive. The disease slowly destroys the memory and the cognition, which eventually impairs one's ability to perform tasks. The cognitive deterioration is a permanent and progressive one. Impairments occur in areas such as in memory disturbance, and it interferes severely with one's ability to perform their activities of daily living. However, Alzheimer's disease does not routinely affect one's level of consciousness. This insidious disease is gradual in its onset, progressive in its cognitive decline, and sometimes we don't even know what the specific causes of the dementia were. So what are some of the clinical manifestations that your patient may present with? There are 10 warning signs related to Alzheimer's disease. These 10 warning signs consist of memory loss that interrupts one's ability to perform their ADLs, their loss of intellectual capabilities, difficulty completing routine tasks at home or at work, confusion with time and place, problems understanding visual images or spatial relationships, difficulty speaking or writing words, losing things without the ability to retrace the steps and locate what has been missing. So this is not the average losing your key, then you just backtrack and you find it. Poor judgment in their daily routine and withdrawal from work and social activities. They can also get change in their mood or personality. There are checklists, and I have attached the link here that you can utilize to evaluate when you're evaluating your patient. When you're doing a physical exam on this patient, you're going to utilize the same systematic process that you would with every evaluation you would do or examination on a patient. You're going to inspect, auscultate, and do a physical exam. Your inspection is you're just going to be looking at the general appearance of your patient, their hygiene, if they have any nutritional deficits, loss of appetite, so they're losing weight, clothes are not fitting. You're going to definitely listen to heart and lungs, and you're going to do your complete neurological exam utilizing the diverse tools that are available. You also want to do a comprehensive lab evaluation on these patients. These labs consist of things like a CBC, a CMP, a thyroid function test, folate and B12, a homocysteine, a methylmalonic acid, vitamin D levels. You can even check an RPR, which is for syphilis, and a CT scan of the head. If you can take a moment, and it was recommended that you purchase a lab diagnostic assessment book, I would ask you to stop these slides now, go to that resource, and then look up these different labs and what would you be gleaning from these labs in reference to a patient who may present with Alzheimer's disease. Also, when evaluating a patient with Alzheimer's disease, like any diagnosis that you ever are doing on a patient or considering, you always want to consider differentials. You want to rule those differentials in or out. So you want to be thinking of things like drug interactions, depression, a stroke, a vascular dementia, delirium. So these are differentials that you have in the back of your mind, and you want to rule them in and rule them out. So how do we manage patients who may present with Alzheimer's? That management would depend on the staging. There are 7 stages in Alzheimer's. I'll give you a few moments to review these because the stages depends on what China treatment you may want to do with these patients. There also will be treatment which will just be supportive. And then if there are any coexisting disease processes, you want to address those as well. And at times there is something called cognitive stimulation therapy that can also be beneficial to people who experience Alzheimer's, but you want to make sure that these patients also are in a safe environment and have individuals who are able to assist them with remaining in a safe environment. Education on the importance of exercise is beneficial to these patients who experience Alzheimer's. There are pharmaceutical or prescriptions that can be prescribed to patients who may be experiencing Alzheimer's. They will consist of a diverse categories of medications depending on the patient's presentation and what you are trying to accomplish. So again, remember we talked about the staging of Alzheimer's. Many of the medications that may be utilized, or some of them, they usually can be utilized on patients who experience mild to moderate symptoms. And then if they have more severe symptoms, then there may be diverse medications that you want to use for those who may have little more severe symptoms from their Alzheimer's disease. So as you see within the past few slides, there are several medications that you should be familiar with that may be utilized in patients experiencing Alzheimer's. The consideration with patients who have Alzheimer's is depression. It is often a co-disease in which they may present with or experience. So you will often see these patients also on antidepressants. Antidepressants such as Celexa, Zoloft, Lexapro, or Remeron. And on this slide, you can see what those dosages range from. One thing about treating any patient with medications, you want to start low and go slow. So you start at the lowest dose and try to see if you can manage some of the symptoms with the lowest dose. And then if not, then you titrate up. But we definitely want to start low and go slow. Now we're going to transition to talking about Parkinson's disease. These are patients who may present with tremors at rest. They have a rigidity, a bradykinesia, and postural instability. You manage these patients based off of their symptoms, and it can range from medications to brain stimulations that can be performed by a neurologist. These patients may benefit from speech and physical therapy and participate in regular exercise. one of the tricks that we have seen with patients who suffer from Parkinson's, if you give them like a ball or a piece of paper or something small that they can kick as they walk, it actually helps them with their balance. Another degenerative disorder is amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. This is a progressive neurological disorder that destroys the motor neurons. Universally, this is a fatal disease, and the survival rate is between 3 to 5 years. You confirm this diagnosis with an electromyography, and at this point, riluzole is the only effective treatment that can slow the progression of the disorder. It does not get rid of it, it slows it. Now let's move ahead to talk about seizures and seizure disorders. Seizures, also referred to as epilepsy, they can be caused by severe head trauma, infections, sclerosis, strokes, and sometimes even genetics. And what happens is we get a hyperexcitability of the brain neurons, or you have a genetic defect of the ion channels. And this accelerates the brain metabolism, which kindles the seizure to occur. So let's talk about seizures and how we define what a seizure is. According to the International League Against Epilepsy, there are 3 conditions which allows one to categorize somebody as having a seizure. One is at least 2 unprovoked seizures occurring more than 24 hours apart. The second is if a patient has 1 unprovoked seizure and they have a probability of further seizures similar to the general recurrence risk after they had 2 unprovoked seizures. And this occurs over the next 10 years. And the last is a diagnosis of epilepsy syndrome. So let's talk about how do we classify seizures. Seizures are classified as either focal, generalized, or unknown. Within the focal category, we have several different types. You have the awareness seizure, the impaired awareness, a motor seizure, a non-motor seizure, or a bilateral tonic-clonic seizure. So there are 5 different types of focal seizures. There are 4 generalized seizures, which are referred to as tonic-clonic, absence, motor, and epileptic spasms. And there is only 1 categorized unknown seizure, which is known as the onset tonic-clonic seizure. As an advanced practice, it is important for you to understand that there are different classifications for seizures, and it is important to accurately classify the seizure that your patient is diagnosed with. Several of the seizure types that are common are focal onset seizures, grand mal seizures, unknown onset seizures, and there is also a focal to bilateral seizures, which means the seizure starts on one side and then it progressively spreads to both sides. Other classification of seizures consist of the Lennox-Gastaut syndrome, and then you can have pregnant women who experience preeclampsia, who also experience seizures, and then seizures such as dacrocystic, post-traumatic, or idiopathic. All are different classifications of seizures. So how may your patient present who may be having a seizure, or what symptoms may they express to you that they're experiencing? They may talk about having auras. They may have a stiffening, a jerking of their limbs, or they may just be staring and into like as if they were staring at something and no other movements. Women who are pregnant and who experience preeclampsia, prior to seizures, they may talk about a headache, blurred vision, photophobia, nausea, or vomiting. So how do you as a clinician evaluate that patient who presents with a seizure or symptoms that you believe may be a seizure? Diagnosis for seizures is confirmed using an EEG, right? But it's important that you take a comprehensive patient history. If there's anybody who has witnessed the seizure, that you get clear understanding of what they have said they've experienced. Do a comprehensive neurological exam and make sure that you collect your blood work to also assist. These patients should be referred to neurology. The gold standard of imaging for seizures is an MRI. Okay. Some of the lab work that you may see being drawn for your patient who may experience a seizure is a CBC, differential, electrolytes, a drug and alcohol screen. You're going to check anticonvulsants because maybe they have a history of seizures and their medications are not at therapeutic levels. And you may want to also do a lumbar puncture to rule out meningitis or any other type of infection. And that leads us to differentials that you want to consider when you're thinking about these patients who may present with symptoms that appear to be a seizure. What could be some other differentials that your patient may be, or disease processes that may be occurring? What other disorders may they have? They may have things like Meniere's disease. It could have been a trauma, hypoglycemia, brain tumors, but there are multiple. And as a clinician, you should always be thinking, if a patient has a seizure, what are some other differentials, or what are some of the causes, and are they causes that can be mitigated, or is that something that if the seizure is something different? So how do you manage these patients? These patients who present with seizures or history of seizures or evaluation to rule out a seizure, you want to make sure that you refer them to a neurologist. Understand what type of seizure that patient may be experiencing. Thus, you can choose the best medication to assist them with hopefully helping them get to a therapeutic state, and possibly surgeries may be necessary. That is not something you would do as a clinician, but it may be something that you would be referred to. It's also important to have follow-up with these patients. Even if your patient is seeing their neurologist, that they have routine follow-ups with you as well to have a discussion on how they are doing. And providing the patient with good patient education about the risk that they now have because of their history of seizures. Risks such as motor vehicle accidents. Can they drive? Adhering to their medications. What things may trigger their seizures? Is it light? Is it sound? Is it smells? Is it medications? Is it alcohol? But having a conversation with your patient about that. There is a diverse number of medications that can be prescribed to your patients who may present with seizures and need their treatment. Here you will see a chart that talks about those diverse medications that can be utilized for your patient. Take a minute to review these, and take a minute to review in your pharmacology book, what are the dosing, the frequency, how do you monitor patients who are on these medications? What does that look like? Do they need lab work? Do they need special testing? What does the physical exam for patients on these medicines should look like? There is a body of evidence out there that shows that sometimes utilizing adjunctive therapy can help with patients who have seizures. And you can see here the diverse things that can help. Also, for patients who experience seizures, it is important for you as the clinician to take the time to help them to understand that a diagnosis of seizure does not mean that they lose their independence. You are going to work with them, partner with them to help them to maintain as much independence as they can. But that takes having a conversation with both the patient and oftentimes family members, or seeking other resources. Now I'd like to move over to talk a little bit about stroke. When you think about stroke, there are some risk factors that patients have that can predispose them to stroke. There are some that are modifiable and some that are not, right? Strokes can also be ischemic, or they can be hemorrhagic. Patients who you think may have a stroke, there are some specific diagnostic tests that will help you to evaluate these patients. And not only are you're looking to diagnose the stroke, but you're also looking to see if the stroke has had an impact on any other body system. So that's where things like your lab works, your chest x-rays, things like that may come into play. Patients who present with stroke, like any other diagnosis that you would have on a patient, is you want to be thinking your differentials. What other disease processes can present with similar symptoms? And you want to rule those diseases in and out based off of your, not only your diagnostics, but you want to rule it in and out based off of your evaluation of this patient. That's your review of systems. That's taking a good history and getting a good family history from your patient. So how do we manage these patients who have stroke? One is adequate tissue oxygenation and possibly antiplatelets if necessary. Patients who have experienced a stroke or following up related to a stroke with you, you want to talk about prevention, how to recognize future strokes, and how do you want to manage, or how does this patient need to be managed? Is the patient on a anti-lipid medication like our simvastatin, our lovastatin? Do they need a cholesterol medication because their cholesterol levels are high? Do these patients need to have further antiplatelet on board? Does these patients have any other health problems like high blood pressure, diabetes that need to be managed and controlled to reduce their risk of having future strokes? Also training these patients on how to maintain the highest quality of life possible and hopefully preventing disability and helping them to cope emotionally with the impact of having a stroke. I would like to now move to talk about some of the infectious inflammatory neurological disorders that occur, things such as meningitis and encephalitis. We have meningitis, which is a word that explains the inflammation of the meninges. Meningitis can be caused by infection, tumors, it could be autoimmune, or it can be drug-induced. There are antimicrobial therapies that can be utilized to help treat these patients, and then you definitely want to do symptomatic treatment and care. When we think about encephalitis, this is inflammation of the parenchymal brain tissue. These are most often caused by viruses. These patients are treated with things like antimicrobials, acyclovir, hyperosmolar therapy. Patients who present to you for evaluation of meningitis and encephalitis, if they are post-diagnosis, then you are monitoring those patients for what symptoms they're currently having. You're helping to educate them on what that diagnosis meant and the importance of continuing and completing whatever the therapy and treatment recommendations have been from their neurologist, or if it was an ER stay in the hospital, helping them to understand what the management will be and having them follow up with you. If your patient presents to you and you think that that patient has meningitis or encephalitis, that is collecting a great history from that patient, making sure that you have documented well, and sending that patient to an emergency room for evaluation. A good habit to get into is any patient that you present to an emergency room for evaluation based off of them coming into your clinic or your practice, you should be calling that emergency room and explaining to them that you're sending a patient on and giving report to the charge nurse of why you're sending that patient and what are your concerns with that patient. There are also infectious and inflammatory disorders such as herpes zoster, which is shingles. We know that as individuals get older, they're at increased risk. Prevention is important for these patients. As patients get older, is that you inquire, have they been immunized against shingles? If they have not, that you offer the immunization. And if they've had shingles in the past, they can still be vaccinated. There are antiviral agents and pain medications that you can prescribe if a patient presents with shingles, things such as acyclovir, and then you can give them like lidocaine patches and things like that that will help to reduce the pain that they may experience from their shingles. Trigeminal neuralgia is also a painful disorder that patients can have from the trigeminal nerve. It is most frequently seen in women, and there is drug therapy that you can offer these patients that will help. I'd like to now move and talk a little bit about Bell's palsy. It's caused by the lower motor neuron. It's usually patients present with a facial paralysis. Most can recover without treatment. However, there are some patients that will present and you want to provide them with steroids or antivirals that can help them reduce the time in which they experience the symptoms. Patients who present with Bell's palsy, just as in any other diagnosis, you want to think about your differentials. So you want to rule out like Lyme disease. So you want to run a line titer on these patients to make sure that that's not a cause. These are patients that you can refer to physical therapy if they present in your office and they're still having their residual symptoms of the facial paralysis, the visual disturbance, or the decreased visual acuity. Physical therapy has been known to be beneficial. These are also patients, sometimes it's hard to get them into physical therapy, so you can print out the exercises that will help these patients to work on that muscle, to regain that muscle strength from the facial drooping. But again, you want to make sure that you think about your differentials and rule those out before you say a patient is presenting with Bell's palsy, because it can present very similar to strokes. And Guillain-Barré syndrome, which is a acute immune-mediated polyradiculopathy. And any patient who has Guillain-Barré syndrome will get IV gamma globulins. So if you think in Guillain-Barré, then the patient needs to be referred to the emergency room for a treatment. Myasthenia gravis is another infectious and inflammatory neurological disorder. It's autoimmune and it's neuromuscular as well. It usually affects younger women and older men. It is a symptomatic treatment with anticholinesterase agents. You're going to treat the symptoms in which they present with. And then we have multiple sclerosis, which is a demyelinated disease of the CNS. It can be relapsing and remitting. It has primary and secondary progression. There is no known cure, but what we do is we treat the exacerbations that a patient can have. I want you to take the time to actually go into your clinical guideline book, and I want you to look at the guidelines. How do you assess the patient with myasthenia gravis? How do you assess the patient with multiple sclerosis? How do you assess the patient who presents with these neurological, inflammatory, or infectious diseases? And then what is the treatment? What is the diagnostics, and what are the differentials? So again, the neurological disorder lecture that you've heard today, this is just an introduction. It's to kind of get you to start to think about these disease processes. I would recommend that you build a chart on like a Google form or a Google Doc, and on that chart, put the name of the disease process. Put who's at risk, who's at the highest risk for getting that disease. What are some of the clinical manifestations you will see with patients that present with these disease? What would your physical assessment and evaluation look like? What is the treatment, both pharmacological and non-pharmacological? What are the diagnostics that should be done? And then what would be your education that you would do? If you would put these disease processes in a chart, I think it'll help you to differentiate them, but also see and learn how to increase your awareness of neurological diseases, how to rule them in and rule them out.